first one who implanted a pacemaker in a patient, and in a way we can look at this talk as the double sending procedure done in them rather than the double switch operation. And here you see one of our double sending patients during his work. And this patient, as a musician, thinks that this here more than AAA ratings is maybe easier to play if you do transposition in this topic. But our transpositions in CHD, it's different because we have a lot of problems with transposition. So we have the atrial tachycardias, we have right ventricular failure, sinus node disease, and the topic of death or sudden cardiac death. And if you look at the incidence of the TGA, even in years of the prenatal diagnosis, it's not so often, but we have a lot of patients, though, with problems regarding to this situation. So, as Katja Weiss showed today, we had in about 166 patients, we have 44 patients, which makes up to 40% of the patients have a pacemaker after the sending operation. And this accounts for about 1/4 of our all patients with pacemakers. And for the ICD patients, we only have 4 patients with ICDs out of this cohort, which makes it rather not too high number. And if you further look at all the late death and extract the one sudden death she talked about, we also have 2 patients who had adequate shocks, which makes it about a 2.6 rate of sudden cardiac death or appropriate shock in this 10 years follow-up. So here, out of 95 patients in one of the first studies, sinus node dysfunction was seen, as we talked about earlier this day. And also the slide was shown. Out of 339 patients, I guess, you have, after 25 years, a risk of about 75% to have arrhythmia. And this arrhythmia is mostly tachyarrhythmia, as we heard about, and it's pacemaker up to 10% here in this study with about 150 patients, 15 years follow-up. So what happens electrophysiology-wise in these patients after the sending operation? We have abnormal sinus node recovery time. We see compression of the sinus nodes, arteries by the CHA lines, and we see hemorrhagia and necrosis in this area, fibrosis of the sinus node. And if you look at the sending patient, especially due to the anatomic concept, there is a shift of the sinus node, which goes from the number 1 here down to number 3, and you have to bear that in mind when you go for ablation procedures in these patients. So what are the pacemaker indications for sinus node disease? It's symptoms related to bradycardia. It's 2A indication. And this is interesting. It's the prevention of intra-atrial oriented tachycardias. And the sinus node here might be secondary to medication or intrinsic. And it's sinus bradycardia with a resting heart rate lower than 40 or pauses over 3 seconds. What you can do, and we did it and others did it a lot, and what is nowadays recommended is that you have to clear the way for the pacemaker leads. And from the Canadian Society of Cardiovascular Society, there is a recommendation that before you look for pacemaker implantation, and I think we talked about this yesterday also, the superior above must be evaluated for stenosis, and if there is a stenosis, then you have to fix it. Is there a specific risk factor after the arterial switch operation? Here in this cohort of more than 800 patients, the group switched the operation technique after half the time, and then you looked at the, if you look after the freedom of pacemaker 15 years after the operation, you can see that, of course, the sending operation or mustard operation is a risk factor to have a pacemaker, and it's also the presence of a VSD because of the AV block risk. So here the pacemaker indication for those complete heart blocks is not different than from the other heart surgery. It's an advanced second or third degree AV block, which persists longer than 7 days after the surgery. And it's syncope or not syncope after surgery when a heart block was there and persisted a bifascicular block. Here we see the follow-up, what happens to the AV node in patients with the ccTGA. This is out of 182 patients. And there is the risk about 2% per year to develop AV block in these patients. And initially about 10% have an AV block. So there's variable connections of maybe 2 AV nodes from the atrium to the ventricle. If you look at histology in these AV node block patients, you find fibrosis, and in EP study you see the conduction delay. So here pacemaker indication, advanced second or third degree block, a white QRS escape rhythm and ventricular dysfunction or ectopy. For the newborn, it's a ventricular rate less than 70 beats per minute. And class 2 indication is after the newborn period, after the first year, average heart rate below 50 or pauses and sinus bradycardia. If you look at the long-term follow-up studies, it has been shown here that the tricuspid regurgitation is a risk factor for the development of death and late failure. And you see here that arrhythmia and pacemaker implantation are risk factor for the development of congestive heart failure and for RV dysfunction. Here the study from Dr. Willing from the early 90s showed that the risk for death is higher in those patients who develop nolorism or atrial flutter and then RV dysfunction. And you can see here the single patient numbers and the incidence of flutter or death in these patients. RV dysfunction, of course, ischemia is a risk for the development of ventricular extra beats, like here in this study with dogs. You see that the incidence of ventricular fibrillation, VT, and premature beat is highly increased after ligation of the left coronary artery. So what are the predictors of the sudden cardiac death after muscular ascending operations? And we saw the slide a little bit different today. This was a case-controlled study, and what they found in 47 patients who suddenly died and were matched with controls who did not die, that the risk for sudden death is increased in those that have symptoms of arrhythmia or heart failure, and of those who have arrhythmia in the, documented either sinus node disease or tachyarrhythmias. Which is interesting, and we'll come later to that medication treatment was a higher risk to die suddenly, and most of these patients were on digoxin. So we know that here in over 8,000 patients that the transposition of the great arteries is one of the not very good prognosis CHDs. And if you look at the different studies dealing with follow-up in these patients, and you see here the year, and you see the follow-up years, range, TGI type, and the patient numbers, you see that the risk for sudden cardiac death is about 4.5% in these patients if you compare all the studies. And one interesting thing is if you look at 2 studies here dealing with the ccTGAs, you see that the risk to die suddenly in these patients is also extremely high. So what about risk factors? And this is difficult to obtain because a lot of these studies, like the Munich or others, had the endpoint for their study not just in death or sudden cardiac death, but in different, like VT, hospital admission. And so it's hard to know what really is a risk factor, but definitely it's RV dysfunction, flutter, tachyarrhythmia. In this last group here, the incidence of ventricular arrhythmias did not predict sudden cardiac death, but in this cohort, they looked at all the congenital heart disease, so not just at the TGAs. So the mortality risk overall is about what we expected for the high-risk TED patients, in about 0.0 incidence per patient year. And this is still tenfold better, though, than those patients who survive myocardial infarction here. Is there an indication to stimulate the patients who come with ventricular extrabeats or tachycardia? Actually, indication is there if there's sustained VT, if there's unexplained syncope and impaired function, or even to be maybe considered, this is, I guess, nearly in all our patients here, with ventricular couplets. So a study from Mark Alexander in 1999 published looked at the all-cause mortality during follow-up. So they stimulated patients who were 95% asymptomatic and looked for the further years what happens to these patients. And looking at all-cause mortality and sudden cardiac death, there was a positive correlation to positive ventricular stimulation, meaning introducing arrhythmia during the study. But you also see that here, these first are death and sudden cardiac death, that this happens also in those patients who were not inducible. And about 25% of these patients here were TGAs. So the ICD indication in ccTGA and dTGA is the spontaneous sustained VT. It's the syncope of undetermined origin, sustained VT or VF induced at EP study. It's EF less than 35% and a bad new heart association classification. And in patients with unexplained syncope, dysfunction, or in patients with sustained VT, and also here with normal function. And one thing which always is debated is about these patients, New York Heart Association 1 and a bad ejection fraction. Is it enough to put a pacemaker in? And we are lucky to have data from patients who had undergone ICD implantation. And this study here is from Kahiri, and he's the one who's looking at all those patient sudden death on the TEDs, and also here even in this patient group. So we have a multi-center group with 37 patients, and the indication for the ICD implantation was in 62% primary prevention. And if you look at the annual appropriate shock rate, you can see that those patients who have secondary prevention have a significant higher incidence of shocks than those for the primary prevention. And if they look at what they did is looking at the independent risk factors for the appropriate shock, and this was the implantation due to secondary prevention, and this is interesting, it was not to use beta blockers. So beta blockers seem to have an effect which is protective against sudden cardiac death if you have a defibrillator implanted. And what is also interesting, and somehow conversely to be looked at maybe, that no patient with inducible VT received an appropriate shocks. So this is interesting. So it seems that it is not predictive to have these patients stimulated. But 35% of the non-inducible patients were those who received the shocks. And what also could be seen when they looked at the ECGs of the intracardiac ECGs of the shocks is that in 50% AT triggers VT, and this comes back to Joachim Hebe's talk. And this is what we see also in common practice when you have here a standing patient with a atrial flutter going on, that they develop VT during this. And when you look at one of our patients here who was shocked, you can see that he has an atrial fibrillation, which leads also to ventricular acceleration, either or due to VT. And then this patient here was shocked. So one last word about how to position the ICD, because the difference is The difference is that the electric field should cover most of the heart. And the problem with the TGA patient is that the lead is in the left ventricle, but the right ventricle, the big muscle mass, is anteriorly located. So sometimes it can be difficult to obtain good defibrillation thresholds, and sometimes it can be more easy if you put the defibrillator on the right side, because then the electric field covers more of the heart. And of course you can have different positioning of the electrodes if you use different techniques, especially in smaller kids. One thing we actually have to worry about, and this is what we have to know, and this is, I think, what we have to tell the families and the patients, is that if you look at the post-ICD mortality, this is not zero. And this is somehow the way that it just reduces the risk of sudden death for about 50%. And this is something which we know also from the AICD trials from the adult world, that if you look at the possibility to die and sudden cardiac death in relation to all causes that you can die, that the ICD group here is only about half the numbers than the control. But this is definitely not zero, and this has been shown also here in this pediatric group, where 5 patients died of arrhythmia after the ICD implantation. So coming to a conclusion, we can say that for the sending and mustard patients, about 40% need a pacemaker during long-term follow-up due to sinus node dysfunction. There is a substantial risk for death due to CHF and tachyarrhythmia, and the annual risk rate is about 0.02% per patient year. Not percent, but patient year. Risk factor here are the systemic ventricular dysfunction. Risk factor for this dysfunction is the sinus node disease. Atrial tachycardias are a risk factor, and we definitely have to get rid of them, especially if we can ablate them. We are happy. Otherwise, we should think about putting all these patients maybe rather on ACE inhibitors on beta blockers or plus. And the risk is also to have, of course, a shock before or near sudden cardiac death. Ventricular stimulation rather does not seem to be predictive in these patients to prevent sudden cardiac death. For the arterial switch operation, and I couldn't find any higher risk for bradycardia or sudden cardiac death compared to other groups. And for the ccTGA, the annual risk about 2% to develop AV block, and there is a substantial group of patients here that die, especially those who have right ventricular dysfunction.